Welcome back to the deep dive. Today, we're looking at a condition you'll definitely come across if you work with young people,
hmm
especially maybe in sports,
hmm
primary care, or if you're revising for, say, pediatrics or sports med exams like the MSRA.
Yeah, absolutely.
Someone actually shared their notes, their revision notes on Osgood-Schlatter disease and asked if we could, turn them into a really high-yield deep dive,
Right.
pulling out the essentials for revision.
Okay.
So that's our mission today. Take these notes on Osgood-Schlatter, sometimes called tibial apophysitis, and just walk you through the critical info.
Sound good.
Like a focused conversation, getting the key facts straight.
Exactly. We'll follow the structure in the notes,
Yeah.
what it is, the causes, who's at risk, how it actually happens in the body.
The pathophysiology bit.
Yeah, that.
Yeah.
And what else it might be, who gets it, how it shows up,
Right.
how we check for it, what we do, and the long-term picture.
Basically pulling out the key points from the source materials you shared. Perfect. All right, let's jump in. First things first. According to these notes, what exactly is Osgood-Schlatter disease?
Okay, so the notes define it really clearly. It's basically an inflammatory condition,
Okay.
and it's located very specifically at the tibial tuberosity.
Which is that bony bump just below the kneecap.
Exactly, on the shin bone, the tibia. And the notes stress it's super common in adolescents, especially when they hit those big growth spurts. So location and timing, key things right away.
Got it. Tibial tuberosity growth spurts. So
Yeah.
why there? Why that spot? What causes it, according to the source?
Well, the notes say the exact cause isn't like 100% certain,
Okay.
but it's strongly linked to repetitive stress
Mm.
or tension.
Repetitive script.
Yeah, specifically stress on the patellar tendon, right, where it attaches to that tibial tuberosity.
Ah,
And the notes list things like running, jumping, kneeling. Those kinds of activities are common triggers.
so it sounds very mechanical, like an overuse thing from specific movements.
Exactly. That's the picture it paints. A mechanical issue from overuse.
So building on that then, who's particularly likely to get this? What are the risk factors mentioned?
The notes point to two main things here. Firstly, taking part in sports that really stress the knee lats bust, bending, running, jumping.
Big sense.
And secondly, as we said, going through rapid growth. Adolescence.
Right.
It just reinforces that image, doesn't it? An active kid growing fast, they're the ones most susceptible.
Okay, let's get into the mechanism a bit deeper, the pathophysiology. How does this actually happen inside the knee based on these notes?
Yeah, this is where it gets interesting, connecting the growth part. It's common in active teens because during those growth spurts, the tibial tuberosity is still partly cartilage.
So it's softer.
Exactly. It hasn't fully ossified, hasn't hardened into mature bone yet.
Okay.
So when the big quadriceps muscle contracts, hard pulling on the patellar tendon, which attaches right there, it can cause tiny bits of damage to this softer area. The notes even call them small avulsion fractures, like tiny bits of bone or cartilage getting pulled away.
Wow. Okay.
And if this happens repeatedly with ongoing activity, you get this cycle of microtrauma, inflammation,
Right.
and the body tries to heal it. But because the stress continues, the healing can be a bit messy, leading to that bony lump you sometimes see.
Ah, so that explains the characteristic bump. It's the healing response to the repeated microinjury on that vulnerable growth plate.
Precisely. The growth plate is kind of the weak spot during that phase.
That makes a lot of sense. Okay, so if a teenager comes in with knee pain, Osgood-Schlatter is clearly high on the list. But what else should be on your mind? What differentials did the notes suggest?
Good point. The source lists a few important ones to consider. Things like patellar tendinopathy, that's tendon inflammation a bit higher up.
Okay.
Patellofemoral pain syndrome, more like pain around or behind the kneecap itself.
Right.
Knee ligament injuries, though usually there's a specific trauma story there.
Mm-hmm.
And just, other general causes of knee pain in teens. It's a good reminder to think broadly at first.
Definitely. Okay, let's shift to the WHO, epidemiology. Who gets this most often? When?
So the notes mention the exact numbers aren't known, but it's definitely common. We know that.
Yeah.
Typically hits girls a bit earlier, maybe ages 8 to 12. Boys slightly later, maybe 12 to 15.
Interesting age difference there.
Yeah. And overall, the notes say it's more common in boys.
Okay.
And they specifically link it to sports like football, basketball, gymnastics, volleyball.
Yeah.
Things with lots of running and jumping.
Right, those high-impact activities again. So given that profile, what do you actually look for? What are the key symptoms and signs the clinical features described?
Okay, symptoms-wise. Pain at the front of the knee. specifically right over that tibial tuberosity bump.
Very localized pain.
Very localized, yeah.
Mm-hmm.
Often swelling there, too. And the pain gets worse with activity, jumping, running, kneeling. They might also mention stiffness. And, like we discussed, you might actually see or feel that bony lump developing. And a key point from the notes, the symptoms usually get much better with rest. That's quite characteristic.
Okay, rest helps. And on examination?
You'll find tenderness right on that spot. Often you can feel some swelling there, too.
Right.
And you can usually reproduce the pain if you get them to extend their knee against your hand, or if you bend it fully, hyperflex it.
Okay.
And here's a really crucial tip from the notes. Always examine the hip.
Why is that?
Because sometimes hip problems in kids can actually present as knee pain, referred pain. So you absolutely need to rule that out.
That's a great clinical pearl, really important point for exams too, I bet. So with such a clear clinical picture, usually, do we need lots of tests? What about investigations?
Well, this is another key takeaway from the source material, especially for revision. Diagnosis is primarily clinical.
Right, based on the story and the exam.
Exactly. The notes say X-rays can be used, maybe to confirm things, check for bony changes like irregularity or fragmentation of that growth area, or maybe if you're not totally sure and want to rule other things out. But in the notes, stress this, they aren't always necessary if the clinical picture is really typical Osgood-Schlatter.
So often no X-ray needed if it looks classic?
Often, yes. You can make the diagnosis without it.
Okay, so diagnosis is usually straightforward. What about managing it? How do we treat this condition according to the notes?
Right, management. It's overwhelmingly conservative.
Yeah.
No surgery usually needed.
Good to know.
The notes list the core things. First, rest. Then, activity modification, so cutting back on the stuff that hurts.
Okay.
And pain management. Simple stuff.
Like ice, paracetamol.
Exactly. Ice is mentioned. And simple analgesia, like paracetamol or ibuprofen, just as needed for pain.
Right.
Physiotherapy is also highlighted as really important.
What kind of physio?
Focusing on stretching, especially quads and hamstrings, and strengthening exercises to improve muscle balance around the knee.
Okay.
Sometimes knee braces or straps are mentioned, maybe for support during activity. The general advice is clear. Rest from painful activities, use ice, tailor exercise to pain levels, and get physio involved, especially if it's taking a while to settle.
And what if it just doesn't get better?
If the pain carries on into adulthood, the notes advise getting a secondary care assessment. But for most kids, it settles.
What about injections? Sometimes you hear about those for tendon issues.
Yeah, the notes specifically say corticosteroid injections are not recommended here.
Okay, definite no on steroids.
Definite no. They do mention some other injections, like dextrose, have shown mixed results, so not standard practice.
Right, and surgery.
Very rare. Really reserved for cases that just don't respond after growth is finished, or if there's a complication like a big fracture fragment. The notes mention surgical options like removing the bony bit, which can work well in those rare, stubborn cases.
Okay, so conservative is definitely the way to go for almost everyone. What's the usual long-term outlook then? The prognosis?
Generally good, according to the notes. Most kids improved a lot with that conservative management, and especially as they finish growing.
When the growth plate closes.
Exactly, when it ossifies. The source says about half fully recover within 1 to 2 years. Symptoms usually disappear completely once growth stops.
That's reassuring.
It is, but there's a key caveat. The notes explicitly mention that the bony bump itself.
Ah, the lump.
Yeah, that often remains. It might still be prominent, and sometimes it can stay a bit tender or uncomfortable, especially when kneeling, even long after the active inflammation is gone.
That's a really important point for managing expectations, isn't it? The pain goes, but the bump might stay.
Definitely. Something to discuss with patients and parents.
Are there any other potential long-term issues or complications to be aware of?
The notes say complications are rare. The main thing mentioned is really just the possibility of needing surgery in those very uncommon cases where symptoms are severe and persistent. But overall, the message is the long-term prognosis is favorable. So yeah, just to pull it all together from these notes, Osgood-Schlatter is that inflammation at the tibial tuberosity in active growing kids.
Right.
Likely due to repetitive stress from sports, diagnosed clinically, usually, managed conservatively, rest, modifying activity, physio, and it typically resolves when growth stops, but that bump might stick around.
That's a fantastic summary. It really hits the high-yield points from the notes. Perfect for revision. Going through it section by section like that really helps it, sink in.
Hope so.
So here's something to maybe think about, building on what we've discussed. We know that bony prominence comes from the healing process on that vulnerable growth plate.
Yeah.
How might actually explaining that mechanism, the why behind the bump to the young person and their family, help manage expectations? Not just about the pain getting better, but about how their knee might look or feel long term, especially with kneeling.
That's a really excellent point. Understanding the why can make a big difference in accepting the outcome, can it? Food for thought.
Absolutely. Well, we hope this deep dive into the Osgood-Schlatter notes has been useful for your revision, whether it's for the MSRA or just for understanding this common condition better.
Yeah, hope it helped clarify things.
And if you are prepping for the MSRA and found this kind of structured breakdown helpful, you might want to check out pastthemsra.com for more resources.
And for some additional free materials to help with your revision, you can also head over to freemsra.com.
Thanks for joining us for this deep dive.